guys, my name is Eva Tovar Hirashima. I'm part of the ultrasound division at UCSD's emergency department, and today I'll be talking about ultrasound guided nerve blocks. I'll specifically be discussing 3 that I believe are high yield for our daily practice and are relatively safe. So if you are nerve block naive, these are the ones that I would recommend you start with. So this is a brief overview of the narrated lecture. I'll first go through the nerve block basics. I'll then describe the setup, and I'll finally discuss the nuts and bolts of the forearm nerve block, followed by the femoral or fascia iliaca compartment block, and finally the posterior tibial nerve block. So the advantages of ultrasound-guided nerve blocks are that they're part of this multimodal pain management strategy that help us provide appropriate analgesia while reducing opiate requirements and their well-known adverse effects. In addition, when choosing regional anesthesia over procedural sedation, there's a clear advantage of the former when considering staffing requirements and length of stay without a significant decline in patient satisfaction scores. Now, the advantage of ultrasound-guided nerve blocks is that ultrasound allows us to visualize the anatomy and the needle, as well as it helps us provide appropriate placement of the anesthetic, and therefore it reduces nerve block failures and its complications. Now, the appearance of peripheral nerves has been described as honeycomb on ultrasound, and you can see an example of this on this still image on the right side. This is the median nerve. And what you can appreciate better on the cartoon on the left side is that each nerve is made up of multiple fascicles which appear hypoechoic on ultrasound, and that these fascicles are embedded within this more hyperechoic connective tissue and then surrounded by the epineurum. Now, each peripheral nerve will be sandwiched in between the fascia, and the fascia will appear as white on ultrasound. And the importance of understanding this relationship whenever you're planning to perform peripheral nerve blocks is that what you want to target is not the nerve itself, but the fascial plane. This stay-away technique will decrease the risks of needle to nerve injury. So as the needle pokes through the fascia and as you inject the anesthetic, what you will appreciate is how the anesthetic spreads circumferentially and bathes the nerve. This is known as hydrodissection. Now, there are 2 approaches one can take for any nerve block. The first one is the in-plane approach. Here, the needle will enter the skin at the side of the probe, and the needle will travel along the plane of the ultrasound. Thus, you'll be able to visualize the entire shaft as it progresses towards the nerve. Now, this is a preferred approach for novices, given that the needle tip is visualized before advancement. In the out-of-plane approach, the needle will enter the skin away from the probe. Here, the needle crosses the plane of imaging and appears as an echogenic dot. Now, an obvious disadvantage of this technique is that you won't be able to distinguish if this dot represents the shaft of the needle or the needle tip. Thus, there's an increased risk of injuring deeper structures without realizing it. So now that you know what the nerve looks like, what hydrodissection is, and the importance of targeting the fascial plane instead of the nerve itself, as well as the 2 approaches to get there, you're almost ready for the procedure. However, like any other procedure, you'll need to follow universal precautions, which means identifying the patient appropriately, entering the appropriate date in the ultrasound, inquiring about allergies and anticoagulation status, and importantly, performing a very thorough and detailed neurovascular and compartment examination. Once you have ruled out any contraindications, you can proceed with consent. And once you get the consent, it's always important to assure that you have the appropriate resuscitation equipment available, as well as placing your patient on a monitor and obtaining IV access. Now, it's always wise to go ahead and pre-scan your patient before you poke the patient, and this will allow you to identify the anatomic landmarks. You also want to set up the room, and you want to place your ultrasound in line of sight. Now, the material that you'll need for forearm or posterior tibial nerve blocks is pretty basic. You'll need a tegaderm, sterile gel, chlorhexidine, a syringe, and a 25 gauge 1.5 inch needle. You'll also want an insulin syringe to place a wheel on the skin. Now, if you're actually planning to do a femoral nerve block, then you want a probe cover, and you also want to have an LP needle, a 20 gauge LP needle will do, as well as a 20 cc syringe and a flush. Now, the commonly used anesthetics are lidocaine and bupivacaine, at least at UCSD's emergency department, because these are the only two that we have. So lidocaine is the anesthetic of choice for short procedures, for example, lac repairs, or if you need to reduce a fracture. And the max dose of lidocaine is 4 milligrams per kilogram. The duration of action is going to be 30 to 90 minutes. Bupivacaine, on the other hand, is the anesthetic of choice whenever the aim of performing the nerve block is pain control, such as in patients with hip fractures. In this case, the max dose of bupivacaine is 2 milligrams per kilogram, and the duration of action is 6 to 8 hours. Now, it's important for you to realize that the risks of toxicity with bupivacaine are quite high, and that bupivacaine can lead to cardiovascular and neurologic adverse effects. It is also contraindicated in pregnancy. Now, there are two other medications that, although we don't have them at UCSD, it's important for you to recognize, and this is chloroprocaine, and this is an ultra-short anesthetic. It's safe in pregnancy. And ropivacaine, the max dose of ropivacaine is 3 milligrams per kilogram, and its duration of action is 6 to 8 hours. Now, the most feared complication of nerve blocks is local anesthetic systemic toxicity, or LAST, and this is a life-threatening adverse reaction that results whenever the anesthetic reaches significant levels in the blood, and it will usually occur within minutes of injection, and there is a dose-response effect. So at lower doses, patients will initially complain of perioral or tongue numbness, followed by lightheadedness, visual and auditory disturbance, tinnitus, muscle fasciculations, CNS depression, seizures, coma, and finally apnea, as well as cardiac arrest. The management is aggressive supportive care, which means pressors for hypotension, benzos for seizures. But in the cases of severe LAST, what has been shown to be effective is lipid emulsion therapy, or intralipid. The dose of intralipid is 1 to 1.5 mg per kg over 1 minute, and you can repeat the bolus every 3 minutes up to a total dose of 3 mg per kg. So before you embark in any type of large volume nerve block, it's really important that you are sure that you have intralipid in your emergency department and that you know how to get it. Okay, so now you are ready for forearm nerve blocks.